Good afternoon, and thank you for joining the RLS Foundation's webinar titled Disability for RLS Patients. My name is Adriana Colucci, and I'm the Communications Coordinator for the RLS Foundation. The 2025 Educational Webinar Series is an RLS Foundation program aimed at addressing integral topics relevant to the RLS community through monthly expert-led webinars. The RLS Foundation is using Zoom webinars for this program. To ensure a seamless viewing experience, confirm that your Zoom Workspace app or browser software is up to date to meet Zoom requirements. Following the live webinar, the recording will be made available for active members to view through their online member portal. If you would like to view webinar recordings and are not a Foundation member, we invite you to join online today by visiting www.rls.org. Please be aware that all attendees will remain on mute during this hour. Following the slideshow presentation, the speaker will answer pre-submitted audience questions. As always, individuals suspecting they may have RLS should consult a qualified healthcare provider. The information offered in this webinar is for informational purposes and should not be considered as a substitute for the advice of a physician. For help accessing the live webinar on your computer, call the office phone number listed on the registration confirmation email, or for additional questions, email info@rls.org. Our speaker tonight is Dr. Mark Buchfuhrer, a consulting assistant professor at Stanford School of Medicine. He's a certified RLS expert and teaches sleep medicine to doctors training at the Stanford Sleep Medicine Center RLS Clinic. He is a member of the RLS Foundation's Quality Care Center network as well. He has a private practice in Downey, California, and is board certified in sleep medicine, pulmonary disease, and internal medicine. He also serves on the Foundation's Scientific and Medical Advisory Board, where he serves on the Foundation's Medical Bulletin Committee, the Opiates Committee, and the Revised Treatment Consensus Committee. Thank you, Dr. Buchfuhrer, for sharing your time and expertise with us today. I now invite you to begin your presentation.
Okay, thank you for that great introduction. And good evening, everyone. And I'm going to go over disability and tell you everything that you hopefully wanted to know and a few things that you may not have known. Okay, so there's a copyright notice here. That's part of the Foundation's notice. And just for conflicts of interest, which actually has nothing to do with this talk, but anyway, I'm a consultant and principal investigator. I have some stock options, and I'm a speaker for Noctrix Inc., which is the company that makes the Nidra bands, which is one of the new treatments for restless legs. And also, I've been a consultant for Azurity, which is the third or fourth company, actually fourth company, that currently owns and distributes the drug Horizon, which is also for restless legs. Okay, so what are the chances of getting disability based just on restless legs alone? And as you can see here, they are very, very, very low. And there's a few reasons for that, which we're going to go over, but I will tell you that my practice, which usually draws some of the toughest and worst restless leg cases from around the country, when I'm done with the tools that we have these days, there are very, very few patients who shouldn't have adequate enough control of their restless legs that they shouldn't have to apply for disability. So typically I like to say that anyone who is wants to apply for disability or thinks they need disability based on their RLS may not have correct or adequate treatment, although there are a few patients, even in my practice, who sometimes cannot get adequate treatment and might be a candidate. Again, as I said, none of my patients have ever gotten or even applied for disability based on RLS alone. I have one current patient who's trying to get disability and does have RLS, but actually the RLS is fairly well controlled, and the patient also has narcolepsy, and it's the narcolepsy that she's trying to get the disability for. So basically, what this is based on is the inability to work or perform daily activities, one or both of those, and often they go together. So this is all based on the government Blue Book, and I'm going to go over the categories in that Blue Book that'll tell you what the government is looking for and what they're going to base any disability that's being asked for on. Again, and it lists all these disabilities that qualify for payments. So, what are the types of disability? One is through the Social Security system, which is, of course, the most common one. And anyone who has, turns, I guess, 62 and older and has elected to get their payments for Social Security is very familiar with that administration. However, there's also private disabilities. Self-employed people, actually a lot of doctors will get disability in case something happens to them and they want to get continued income. And many employed people may get it through their company or pay for it themselves. So the Social Security Administration will pay the disability benefits through two different programs. The more common one is probably the SSDI, and this is for people who have worked and paid into Social Security. And it's based on what you put in your earnings, kind of similar to getting Social Security payments when you turn older. And again, if you maintain the SSDI eligibility for 2 years, you will automatically get Medicare coverage. And that's why a lot of people who are under age 65 can qualify for Medicare coverage. The other program is the SSI, or Supplemental Security Income. And to be eligible for SSI, you have to have limited income and resources. You have to be a US citizen or national living in the United States. Again, the monthly benefit is based on need. So the amount that people get can vary, but there is a maximum amount. And in some states, they'll add that to the federal rate. In most states, those who are eligible for this SSI are automatically eligible for Medicaid. And what's interesting is to get this, sometimes, especially for Medicaid, you have to really go down to very, very low, both income and how much money you have in the bank. So sometimes these are quite difficult. So here are the Blue Book categories. And there's a whole bunch of them there. Obviously, respiratory disorders. I'm also a pulmonary specialist, so I see patients with bad COPD. And I have had patients qualify for disability due to severe COPD. Often they're dependent on oxygen, and it may not be that difficult for some of those patients in general, but it's still a difficult process. But of course, many of the other categories here have nothing to do with restless legs. The category, I don't know if my pointer will show it here, but the neurologic diseases, where you see in the middle column 11.00, is probably one of the closest ones, and also the mental disorders. So I'm going to elaborate on those categories. So here are the neurologic disorders, and the one that I've picked out, because as you can see, there's a whole bunch of ones that have nothing to do with restless legs. If you look on the left column, things like epilepsy, Parkinson's disease, multiple sclerosis, you can see how these people would qualify for disability, but we'll use the peripheral neuropathy because that's probably the closest we'll get in this neurologic category. And remember, there is no category that says restless leg syndrome. So for peripheral neuropathies, what they want to see is it has to have a disorganization of motor function. That's your ability to do things with your arms and legs. And they describe it in section 11.04b, and they have to be there in spite of treatment. So if you get successful treatment, you can forget it. So here's that 11.04b. They want to see a significant and persistent disorganization of your motor function in two extremities. So it can't just be one. They want two extremities, and they want this to result in a sustained disturbance of gross and dexterous movements or gait and station. Station means you can't stand. So then we have some mental disorders, and you can see the ones in the red are the highlighted ones, which I'm going to go over now. And certainly many patients with poorly treated restless legs that are still very active may have a lot of these issues, so we'll go over them. The first one is the 12.04, which covers psychiatric stuff like depression, bipolar, and related disorders. But with these, you have to satisfy A and B. And the first slide only has A, and you'll see how difficult this can be. So for A, you need to be depressed, have significant depression, but you need 5 or more of this list. So you have to have a depressed mood. That probably is not too tough. Diminished interest in almost all activities, appetite disturbance with a documented weight change, sleep disturbance. That shouldn't be too hard for a poorly treated restless leg patient. Now, observe psychomotor agitation or retardation. Really, the one here is agitation. Patients with bad restless legs may get very agitated because they're not sleeping well and they're waiting for the restless legs to come, so they can have a lot of anxiety and agitation. Decreased energy. If you're not sleeping, you might qualify for that. Feelings of guilt or worthlessness, probably less common. Now, difficulty concentrating or thinking. Hey, if you're not having adequate sleep because of poorly controlled restless legs, those will surely be very likely. And thoughts of death or suicide, hopefully that doesn't come to that, but we have had patients with severe suicidal ideation. They think about death, and we've had several who've committed suicide because they haven't had adequate treatment. So certainly several of these categories may apply, and it might not be that hard to get 5 or more with a poorly treated or restless leg patient or one, and it may not, they may even have a good doctor, but they may not, be able to tolerate medication or get responses from treatment. Then we have part B, and for this you have to have extreme limitation of one extremity or marked limitation of 2 in the following area. Oh, sorry, not extremities. This is more the psychological stuff. Sorry. You have to have trouble understanding or remembering or applying information. Certainly, if you're sleep deprived, that can happen. Interacting with others, that's harder to say. I mean, if you're sleep deprived, certainly that's possible. And concentrating, persist or maintaining pace. That's more if you, the concentration is probably more appropriate for restless leg patients. Maintaining pace means, you have some issue where you can't, if you have a job that requires activity that you can't keep up. And of course, the last one is adapt or manage oneself. It would have to be pretty bad restless legs to have that kick in. So probably for this one, you can get the first and the third might be relevant for someone with poorly controlled restless legs and significant sleep deprivation because of it. Then we come to anxiety. Obsessive compulsive disorders probably does not apply, but the anxiety certainly does. I've had patients who see me initially and are extremely anxious because of their poorly treated restless legs. Here, you'll see there's 3 categories under it, A, B, and C, and you have to satisfy it with A and C or A and B. And some of these categories you'll see repeat a little later because it's kind of relevant for some of the mental and other disorders. But the first is anxiety disorders, which again are pretty common. And a lot of these I would say almost all of these, restlessness, easily fatigued, difficulty concentrating, irritability, muscle tension, hard to know, that probably goes along, and sleep disturbance. I would say those are probably very common in poorly treated anxious RLS patients. Um, the second part of this is panic disorders with agoraphobia. That's people who can't go outside. Panic disorders, I don't see that as often, although I have patients who have previous issues with panic attacks, and once they get the restless legs, that puts the panic attacks into hyperdrive, but it usually isn't directly from it, although it certainly can happen. And the part B there is disproportionate fear or anxiety about at least two different situations. And they give a thing like you can't go in public transportation or in a crowd, or things that might be relevant, for your home. That's like the agoraphobia, where you can't leave your house. Okay, and the third part of A is more of the obsessive compulsive stuff, involuntary time-consuming preoccupation with unwanted thoughts, repetitive behaviors. I would say this is not something that we see except in patients who are on the dopamine agonist drugs like the pramipexole, Mirapex, or ropinirole, Requip, where they can get compulsive behaviors. And that's due to the medication rather than the disease itself. But if someone can't get off one of those drugs and has those issues, certainly these then may apply. But I would say that this category is a little bit less. Okay. Then we go to part B for anxiety and obsessive compulsive disorders. Again, this is kind of somewhat similar to what we discussed before. Understanding, remembering, and applying information, interacting with others, the concentration, and adapting or managing oneself. So, as I said, you'll see this repeat because it's all very common to the mental disorders. And then you have part C. So remember, you have to have A and B or A and C. It gets really tricky here in this. This is something that often you'll need significant help from often an attorney or someone who's a professional, because it can get very complicated. So if your mental disorder in this listing is serious and persistent, that is, you've had it for over 2 years and it's not doing well, you have to satisfy the two criteria that the medical treatment or therapy, psychological support, or whatever you're getting, that's ongoing, and you only have a marginal adjustment, that you really can't change your environment or demands that are part of your daily life. So it's kind of a little awkward statement, but it means that you're being treated and you're still not doing very well, and you really can't cope. Okay, so here we come to a different category, 12.07. And they're talking about somatic symptoms. So the word somatic applies to bodily function, not the brain. So something that is like anxiety or depression is kind of more in the brain. Somatic has to do with the body. And you need medical documentation of one or more of the following. And there's three things. The first is symptoms of altered voluntary motor or sensory function that are not explained by another disorder. So, for example, if you have a tremor, and we know it's due to Parkinson's or something, that would exclude you. Or if it's what we call a benign essential tremor, which is a known thing, that doesn't count. It would have to be something that is due to the restless legs, and I guess one might think that you could include the periodic limb movements, especially if they occur and are very distressing while you're awake during the daytime, or they prevent you from getting back to sleep. That might fit in there, but that's the only thing that might, but even that is explained by the restless legs, so it's explained by a medical disorder. So this is kind of a little tricky. The second one is that one or more somatic symptoms that are distressing with excessive thoughts, feeling, or behavior related to the symptoms. And what that would be is if the restless legs are so bad that they cause, that's all you can do is think about the restless legs, and it's kind of making you not be able to do anything else. Again, that's, these are kind of hard things to prove. And sometimes you might even need a psychiatrist for this type of stuff. And then preoccupation with having or acquiring a serious illness without significant symptoms present. Well, of course, we know restless legs is a serious illness, especially when not treated well. So that doesn't really count. This is more body stuff that occurs kind of because of a psychiatric disease, but indirectly. And again, with this, you need the part B, the extreme limitation of 1 or a marked limitation of 2. I'm not going to go over these again. These are the exact same things we talked about before. So remember, with the blue book disorders, there is no category for restless legs. So you can't, if you just go in and say, I have restless legs and that's all it is, you will be disqualified right away because you have to be in one of the categories. Therefore, your disability is only based on whatever symptoms you have from your poorly controlled restless legs that overlap or would make you applicable for those things we just discussed in that blue book. So if they don't cause those issues or symptoms in the blue book, you will have zero chance to get disability. And again, and you have to prove also that these symptoms are directly caused by the restless legs. And again, if they're, especially when there's severe depression, anxiety, it may not be too hard to prove that. And especially with restless leg patients, treating the anxiety and depression often requires medications that may make them worse. So that part may not be that difficult, but making sure they match up with the categories in the blue book sometimes can be very difficult. So just to go over the type of symptoms they want, we've discussed many of these before, but they usually want 5 or more of these: depressed mood, diminished interest in nearly all activities, the change in weight, which I don't see happen that often with my restless leg patients unless they have extreme insomnia, difficulty sleeping, which is common, noticeable physical agitation, I see that a lot, less energy, not uncommon, feelings of guilt or worthlessness, possibly, but I don't see that much, difficulty concentrating, I certainly see that until they're well treated, and thoughts of death or suicide, I've seen that. Patients have told me they've definitely thought of that prior to getting good treatment for their restless legs. So the other thing the other issues are 2 or more of these, and we had these up a few times: understanding, remembering, or applying new info. Not uncommon. Interacting with others in the workplace, not as common. The concentrating and completing tasks, certainly. The adapting one, I'm not sure, but that could also happen if they're very sleep deprived. So how do you apply for disability? So there's a website, which I have up here, www.ssa.gov/disability. Even if you don't have that, haven't written that down, you can put government disability, that will surely pop up. And what you have to be prepared is to show that you cannot make a living or work due to that restless legs, but then due to all those categories that are caused by the restless legs. Make sure you have a doctor who is very familiar with restless legs. As I'm sure many of you out there have experienced, your doctors know very little about restless legs and think that it's just a trivial disease and certainly couldn't cause anything. Unfortunately, if they haven't walked in your shoes, they may not really have a clue as to how bad the restless legs can be. Your doctor will have to fill out a form called the residual functional capacity form on your behalf. And I've never done this for restless legs, but I have done this for COPD. And really, this is something that you show that the person can only work, a limited amount of time, or they can't work at all, or they can't walk that far, or because of, well, in my case, it's usually COPD, or they can't lift anything over 5 pounds or whatever it is. It's a pretty complicated form. And again, if your doctor is not familiar enough and takes the restless legs credibly enough, they'll have difficulty filling that form out. And they'll have to notice any medications you're taking and their side effects, very common with restless leg patients, especially if you're trying to treat anxiety and depression. They'll have to go through the jobs you've had in the past and the exact physical activities you can no longer perform. And again, it's difficult, certainly if your job is a sedentary job where you have to sit all day, which really can drive the restless legs crazy. They can easily document that you can't do that. Whether you then can't do something that requires walking or whatever is harder to say. Whether they'll say, oh, you can do another job, which may disqualify you. So again, this can be very difficult. And again, how long you've been undergoing treatment for your restless legs and associated disabilities, and any other conditions you have that may contribute to your inability to work. The more things you can list that make it difficult, the better chance you have. And again, as I said before, if you have a sedentary or desk type of job, physician statement saying the limitations. For example, if you sit more than 30 minutes, an hour, 2 hours, your restless legs will drive you crazy and you can't do that. So the problem is there are typically no tests that support the diagnosis or disabilities for restless legs. It's easier if you have someone, like with COPD, I have lots of tests. I have breathing tests that'll show it, oxygen levels. We can actually walk them and say they can only walk so far, so they can't do much. So I can document a lot of things with simple tests. There really are no tests that can justify the disabilities of restless legs. So here's what's interesting. About 30% of all applicants, and I'm talking people with even horrendous disabilities, and I've put a bunch through, and I have patients who, even with oxygen, can barely walk 5 to 10 steps. And I can tell you, many of them get rejected with their first application. And it can take up to a year to hear back after applying. And I'll tell you just a quick anecdote about the patient I told you earlier that I have who has restless legs and narcolepsy. And the narcolepsy is very hard to treat in this particular patient, so she really has a true disability. She went 9 months after putting the application in to find out that the person who was supposed to review her application quit and went away and was not doing anything anymore. So it then took another 6 to 9 months to get another person assigned to her case, and she's probably 6 to 9 months into that new application waiting to hear back. So you can see how things are going. And this is before we had the new administration in, who is cutting back on government workers left, right, and center. So I would assume, hopefully, hopefully I'm not correct on this, but in, with the people doing disability, there probably will be cutbacks there too. So what I've told you before may in fact be more optimistic and it may take even longer. So you may appeal if you get denied to something called the Office of Hearing and Appeals, OHA, the appeals councils and the court system. However, you will need a lawyer to appeal to an administrative law judge at this Office of Hearing and Appeals. The other issue, as I said in the beginning, is that most patients should have adequate resolution of their restless leg symptoms, so that applying for disability should in fact not be necessary in the vast majority of our restless leg patients. So here's my last slide. And unfortunately, I would say the success rates for disability based on restless legs are probably as good as going to Vegas and hitting the big jackpot. So that's the end of my talk, and I'm more than happy to answer the questions. Uh,
Thank
Adriana?
you. Yes, yeah, thanks for your presentation. We do get a lot of questions about it, so it's good to address this topic. We just have a few pre-submitted questions with registration related to this topic, and you've addressed them, but we'll just use this opportunity to summarize.
Okay.
So the first question is RLS considered a disability? And if so, how can I apply?
Yeah. So I think we discussed that in
Yes.
great detail. That unfortunately, RLS by itself is not considered a disability, but only the medical issues caused by the RLS, if they happen to coincide with one or several of the categories in that blue book, will ever be considered a disability.
How often is disability granted with RLS as the primary reason, which we
Yeah.
discussed? Yeah.
Well, again, I don't know the overall answer. I mean, there could be other doctors who have submitted bad RLS cases um, and gotten disability. But as I said, in my practice, I have not had a single patient. But again, I'm a little different in that very, very few of my patients do not have very good relief of their restless legs by the time I'm done. So very few of my patients would ever even think about applying for disability. And I definitely do have some who still have significant RLS just because they're very difficult to treat. Um, but again, I've just not had anyone except my one RLS patient who is applying for another reason, although she is using the RLS partly to help support the narcolepsy.
Would you say it's more helpful to use RLS as a secondary claim?
Yeah, it might be, for example, if you had like COPD and you have RLS, certainly adding the RLS and everything it does might help you get you over the finish line for disability, whereas maybe the COPD or some other problem that you have might not have done that.
Okay. Thanks. I just have one last question for you, slightly veering off topic here. Can you address the disabling effects of what is called, or what this individual calls, restless torso syndrome, which is RLS experience in the upper body?
Okay, so that's a very, very easy question to answer. So what happens is RLS always starts in the legs, but then may progress to other body parts, especially in patients who who have dopamine induced augmentation. They've been on Mirapex, Requip, Nupro, whatever. And then what typically happens, the RLS then goes next to the arms, and after that, it can go to the torso. And in a very few cases, I've seen 10, 15 cases in my thousands of patients that I take care of, 10 or 15 patients who actually have it in their head, which can be very disturbing because imagine sitting there and trying to move the muscles in your face and head to relieve your restless legs, especially if you can't walk or move otherwise. So getting in the torso just indicates that the restless legs is more severe, but whether the restless legs is only in the legs or it's in the legs, arms, torso, face, head, wherever, it's still just restless legs and it's treated exactly the same.
Is is the progression to other body parts strictly associated with augmentation, or can it just be a natural progression
Yeah,
without hits of dopamine?
it can be a natural progression. And of course, um, one of the tough things about doctors not recognizing augmentation is that uh, they assume it's just a natural progression of restless legs. And I can't tell you how many patients I see, and this is probably with this issue I'm going to describe, this is probably the commonest reason why patients end up on massive doses of the dopamine drugs, because they're put on a dopamine drug, they get better, but then they get worse, and it could be months later um, or several years later. And the physician who's treating them just says, oh, must be natural progression, especially if it's a few years later. They give them more of the dopamine medication, and the patient will get better for a while, but then their RLS keeps getting worse. And it's just easy for the physician who's not that well versed in restless legs to say, oh, this is just a patient who's having naturally progressive worsening restless legs, and the only thing I can give them is a dopamine drug until they get to a level where they say, whoa, I can't give any more. I'm now uncomfortable giving more. And the small exception to that is neurologists who don't understand restless legs that well, but are very comfortable giving very high doses of the dopamine drugs for Parkinson's disease. So their upper limit is usually tremendously high.
Well, thank you again for your presentation today, and thank you so much to our audience for joining us today. We hope that we see you at our next virtual event, which is actually taking place next Friday on May 2nd for a virtual town hall discussion, where we will collaborate with other sleep health organizations, researchers, and clinicians to discuss the changing landscape of U.S. healthcare for patients, families, clinicians, researchers, and sleep health organizations. For more information on that, of which Dr. Buchfuhrer will be a presenter as well, you can visit www.rls.org. Thank you so much. Have a great night.